Sì, un compagno di un liceo che si chiama Baruffaldi, che era uno dei Baruffaldi, quelli degli occhiali.
We start with the final dissertation, and welcome to University of San Raffaele, Vita-Salute University, and my personal appreciation for Dr. Foquintest as representative of general practitioner. And we start with the first candidate, Mr. Cristina Baruffaldi, with final dissertation on towards precise medicine in the treatment of congenital hypothyroidism, therapeutic assessment in the first 3 months of life, with Professor Alessandro Aiuti.
Yes, good morning, everyone. I'm going to present you this study I've worked on in this last year with Professor Aiuti and Dr. Vigone. We really wanted to focus on the importance of precision medicine, which will be implemented more and more in the future. And we concentrated on the treatment of congenital hypothyroidism, with a particular assessment of the therapeutic strategies to be adopted in the first 3 months of life. Here in the picture, you see the typical appearance of a child affected by congenital hypothyroidism. However, nowadays, it's rarer and rarer to see this kind of clinical scenario or all the symptoms you can see listed on the right. In fact, since the 70s, screening at birth for this pathology has been implemented, thus allowing a precocious early diagnosis together with an early treatment for these children. However, besides this, there are 3 cases of over-treatment and over-treatment who sometimes happen in our patients. And this is a risk for the patients we treat, since this phenomena may lead to adverse neurocognitive sequelae that must be avoided. Furthermore, with the passing of time, the concept of precision medicine has been spreading and getting more important. This will be the medicine of the future. That is a kind of medicine that is not based on a single dose of therapy, for example, given to everyone in a general way. But for sure, every patient should receive a proper treatment according to the characteristics, the peculiarities he may have. And in particular, when talking about congenital hypothyroidism, we should consider, for example, the disease etiology when giving the therapy, the age of the patient at the moment of diagnosis, the fact he may have other comorbidities, the fact he may take other drugs. So therapy personalization is an aim we must reach, absolutely. With all these premises, we decided to perform a study that was a retrospective monocentric one on 157 children, babies born in different hospitals of Lombardy region affected by congenital hypothyroidism and showing dysgenesis or a gland in situ. Our aim was the one of demonstrating which could be the best therapeutic management to be adopted in all these babies who were treated by a liquid formulation of levothyroxine containing alcohol. We enrolled patients who were screened positive for congenital hypothyroidism at birth and that were born, as I was saying, in different hospitals of Lombardy region. And then all these children were confirmed to have congenital hypothyroidism in Hospital San Raffaele, that is a reference center for the disease. In fact, in the world of pediatrics, they were tested for TSH, FT4, and FT3, and they were analyzed and scanned by ultrasound in order to understand the etiology of their disease. Children who didn't show a gland that was typically located in its usual place also were scanned with thyroid scintigraphy in order to understand the correct etiology of the disease. This allowed us to divide these patients into groups, the one with a gland in situ and the one with thyroid dysgenesis. And you must consider that in this category, we included patients with thyroid hemiagenesis, ectopy, and agenesis, since these pathologies generally have a similar degree of severity. Furthermore, in order to better evaluate the severity of the disease these children had, we evaluated their TSH and FT4 at the moment of diagnosis by dividing these children in different groups according to the ranges of TSH and FT4 they showed. Then we followed up all these children at 7, 15 days, 1 month, and 3 months after the beginning of the therapy. And here you can see resumed all the data regarding the children we observed and treated at the moment of diagnosis. You see a comparison of the TSH, FT4, FT3 dose and days of life at the moment of therapy between patients with thyroid dysgenesis and a gland in situ. And what is interesting to notice is that patients with thyroid dysgenesis tended to have higher values of TSH, but lower values of FT4 and FT3 in comparison with the other group. On the other hand, they received a higher dose of therapy, and this is a characteristic that is typical of patients showing this kind of etiology. The statistical analysis we performed were always significant when comparing these two groups. Here instead you see listed the data regarding TSH, FT4, and the dose of therapy that we gave to our patients at 7, 15 days, 1 month, and 3 months after the beginning of therapy. And what is interesting to notice is that the values of TSH, like the one of the dose of therapy administered, were always statistically significant in terms of difference between the two groups. On the other hand, FT4 showed a statistical significance only at 7, 15 days. Here instead, we wanted to better evaluate the quality of the treatment performed by dividing our patients into well-treated, over-treated, or under-treated according to the values of TSH recorded at 1 month and 3 months, which were put in comparison with the range of TSH observed at the moment of diagnosis. And what is interesting to notice is that children that at diagnosis showed a TSH superior to 100 microunits per milliliter showed higher rates of undertreatment. And this is also quite typical due to the fact that these patients need a longer time in order to normalize their values of TSH. And of course, this is a data important for us in order to understand that we must properly tailor the therapy, especially in this kind of patients. In order to evaluate the variability also of the dose administered to our patients and to understand practically which kinds of factors affected the correction of the therapy we performed at 1 month, we did a multivariate analysis of variance that allowed us to see that there was a variability of 61% in therapy correction, in therapy dosage, and the factors that most importantly allowed us to decide how to tailor the therapy at 1 month were the etiology of the disease, the FT4 at 7-15 days, and the dose given to these patients at 7-15 days. Instead, in order to compare the trends of therapy reduction we performed along the time at the different follow-ups, we did a repeated measures ANOVA, and from the graph you can see that the strategy of correction of the therapy we performed is quite similar in the two etiological groups of treatment. The main difference was related to the fact that patients with thyroid dysgenesis received higher dosage. And as we can see, we got statistical significance regarding the fact that dose is generally adjusted according to the etiology and the passing of time. To conclude, we did a similar kind of analysis for patients that resulted well treated, because our aim was to demonstrate which is the right dose to give to patients that were well treated and showed a normal thyroid function. Here you may see all the dosages we gave to these patients, and once again we can see that patients with thyroid dysgenesis received higher doses of therapy. But the interesting thing is that we also calculated the percentages of reduction of the therapy. And this was interesting and useful also from a practical point of view, since it gives to doctors a practical strategy in order to understand how to reduce the dose of therapy in our children. So, to conclude, our study demonstrated the absolute importance of tailoring properly LP4 therapy as in the first 3 months of a baby's life, which are the most delicate ones in order to guarantee a correct development of these children. Furthermore, we observed that FT4 is fundamental, especially at 7-15 days after the beginning of treatment, in order to understand if dose adjustment is correct, while TSH got an increased importance from this point of view at 1 and 3 months. Furthermore, we understood that patients affected by thyroid dysgenesis need to be even more properly assisted in therapy correction, since they show a higher risk of undertreatment or overtreatment. Furthermore, we advise to perform a follow-up that should occur every 7-15 days in order to screen as soon as possible cases of undertreatment and overtreatment that must be avoided. Thanks for your attention.
Thank you, Mrs. Marufaldi. Very well done. Good job, and your expression was very good. Any questions?
Yes, thank you for a very nice presentation. I think this shows clearly the importance of another screening and the importance of personalized adjustment of the treatment. So I have 2 questions. One is related to the guidelines or let's say algorithm that you have identified. Do you think that this could be extended also to other centers? This has been developed here at San Raffaele Hospital.
Yes.
It could become also a recommendation for other centers in Italy and Europe.
Yes, for sure. For what concerns the algorithm of screening, there is a common one that is used in Lombardy region, but the problem is the period following screening, because we have a proper strategy of screening, but we don't have a proper strategy of follow-up, because until 3 months, for example, we have an advice to give to all the children a dose of 10-15 micrograms per kilo of LT4, but this is for sure not enough. We have to work in this field in order to understand how to properly correct and adjust the therapy after screening. And of course, this strategy should be shared among all the hospitals, since we are a reference center. So we study these children, we know and we'll better know how to treat them, but not all the centers, of course, are that precise in giving therapy.
Right. And the second question regards in the population of children infants who had thyroid agenesia. Did you find any genetic diseases did you identify the mutations in genes?
Yes, there may be mutation of particular genes, but actually in our study we didn't focus on this aspect. We in fact observed that generally patients with thyroid agenesis that were included in the category of thyroid degenesis, not particularly noticing the genetic aspect, but for sure, for example, this is a hint we could use in the future to perform other studies in order to increase our knowledge about these patients and to better understand how to treat them.
Question?
I think maybe Dr. Vigone, who has followed with Varufali,
I thought prima con la dotta Anne del ability to manage all this data. I have two questions. One, why is it also important to evaluate the therapy at 7 and 18 months, and why did you consider TSH at 1 month and 3 months for the same purpose?
Yes, FT4 respect to TSH requires a shorter time in order to get corrected due to the fact that TSH has a longer half-life. So the first response we see at the moment of therapy correction is FT4. That's the reason why we give a major attention at least to FT4 at 7-15 days. On the other hand, TSH is more precise in order to understand thyroid function and the appropriateness of thyroid function. That's why at 1 and 3 months, we prefer to use TSH that may need up to 10 weeks to normalize, and that's another reason for which we don't use, or at least we consider it less at 7-15 days.
And then the second question, which are the possible perspectives in order to personalize the therapy of the
For example, we may perform prospective studies in order to better understand how a therapy was actually adapted to our patients. And like I was saying before, for example, we could observe in a stricter way the characteristics of the patients we have, for example, from a genetical point of view. So we, in the future, could try to consider our other parameters also that may allow us to understand how to better tailor the therapy. Thank you.
The
Yes, it is a kind of therapy that it is already given and it is already attempted, especially in this center. With Dr. Vigone, we saw some patients receiving this kind of therapy. At the moment, however, in this hospital in particular, we are trying to understand better which are the right patients to give that kind of therapy and how to properly tailor the dose of LT4 and LT3 given in order to guarantee the best thyroid function possible. Thank you.
Congratulations.
Thank you.
And you can go out.
Thank you.
And we decide.
Thank you.
La foto c'è lo stesso, da far entrare i parenti, far entrare lei. Medaglietta? Ce l'hai la medaglietta? No? Non ci sono più le medagliette? No? Allora ho saltato un turno.
Are you excited? Yes.
Yes, hello.
I declare that the graduate Cristina Baruffaldi has fulfilled all the requirements on the master's degree with comprehensive final grade of 109 out of 110, and by virtue of the authority vested in me by the Italian law, I confer her the master's degree in medicine and surgery and license to practice. Congratulations.
Thank you. Thank you a lot for your attention.
Thank you for your work.
Thank you. That's for you. And you remember all your life that you will be in San Raffaele University.
Yes, for sure.
Okay.
Thanks a lot.
Thank you.
May I go out from the left, from the right?
There. Only circular phrase.
Sì, adesso andiamo dal remoto. Dai, su.
Eccola. Good morning.
Can you hear
Good
me?
morning. Yes, now perfectly. Can you hear me?
Okay. Okay. Good morning.
Hi.
Are you excited? No, you are at home. You are not excited so much. Okay. Good morning. We're starting with the final dissertation of Beatrice Barbarini, the thesis with Professor Cavallaro, clozapine to non-clozapine ratio in the treatment-resistant schizophrenia, clinical implication from psychopathology to cognition. Please.
Okay. I would like to introduce the work done from Beatrice. I was pleased to accept this kind of title and of research, also because for me it was a sort of back to the future. My work of degree in the far 1987 was just about the metabolism of haloperidol and clinical response. But many years have passed, and that seminal but very simple kind of work that I did at that time at the Policlinico Institute in Milano, at the Statale University in Milano, has changed across the years and has been dedicated also to the look at the influence of the metabolic pathways and their effects not only on clinical response intended as a psychopathology, but also of cognition. And we know that for an illness that Emil Kraepelin at the beginning of the last century called dementia praecox, deterioration in cognition is a core aspect of schizophrenia and one of the main endophenotypes of the illness. So this work went to look at an important aspect of the therapy of schizophrenia that serves a high level of utility in patients with resistant schizophrenia, that is, schizophrenia resistant to common drugs, and that respond in a great part of patients, of the samples of patients, to this drug that is clozapine. Clozapine is a special drug, has a very complex pharmacodynamic profile, and this work went to address a question if its metabolism, and in particular the ratio between the metabolite, the main metabolite of clozapine, and the clozapine itself were related to changes in clinical aspects and cognitive states of the patients. Our group is doing a lot of work about this with your assistant coordinator, that was Dr. Marco Spangolo, and we have many lines now on research in resistant schizophrenia. So your work is within the mainstream of the research of our clinic and our group. So briefly tell us the main aspects from which you started, what did you do to realize this study, and what are the results? Please.
Okay, shall I share my presentation now?
Yeah.
Okay.
Just a moment.
Can you see?
Yeah.
Okay. So as it was introduced, first of all, welcome everyone, and thank you for your attention. I would like to, as Professor Caravallaro before me said, talk about the role of the clozapine to norclozapine ratio in the context of the treatment-resistant schizophrenia, and all those clinical implications that range from the psychopathology itself up to cognition and cognitive deficits. So, schizophrenia is defined by the World Health Organization as a chronic, complex, and severe mental disorder characterized by distortion in thinking, in perception, in emotions, in the sense of self, and in behavior. The lifetime prevalence of the disease ranges between 0.3 to 0.7%, with the difference in incidence between males and females. And also the onset is different among genders, as it is between 15 to 25 years for males, and later between 25 to 35 for females. In order to diagnose the schizophrenia, you have to recognize a multitude of clinical features, as it is a very complex disease, as we said. Among them, you find positive symptoms such as delusions and hallucinations, the negative symptoms such as apathy and avolition and social reclusion, and also cognitive impairment. In schizophrenia, cognitive impairment is involving all areas of cognition, is a generalized dysfunction, and all those areas are found at the level of the frontal and temporal lobes, and are actions that involve problem solving, abstract thinking, planning, working and episodic memory, but also the social cognition. Social cognition is moreover impaired from the more moderate way to the more severe way, but in virtually all patients with schizophrenia. It's something that happens even before the onset of the disease, and it is a strong impactor of the long-term functional outcome of the patient. Moreover, cognitive impairment seems not to be influenced by current medications, and even when the patient is in remission of positive symptoms, cognitive deficits seem not to wane, as they are two completely different entities. The treatment for schizophrenia is based on pharmacological therapy with either first or second generation antipsychotics, also known as typical or atypical. They share a main mechanism of action, it being a dopaminergic antagonism with an added serotonergic antagonism for second generation antipsychotics. This will mean that the pharmacological profile and the side effects of the drug will be different among classes. However, the endpoint result in terms of efficacy is similar, as they share great efficacy on positive symptoms, little efficacy on negative symptoms, and basically no efficacy on cognitive symptoms. Clozapine is a peculiar drug as it was the first second-generation antipsychotic that was ever created. It's a 50-year-old drug. However, it still remains one of the most efficacious, even if we still not understand completely the reason why it is. It is able to have an effect not only on positive symptoms, but also on negative and possibly on cognitive symptoms as well. And the reason lies on an array of neurotransmitters that are affected by the drug. First of all, it is a weaker D2 antagonist and a stronger serotoninergic antagonism compared to the other second-generation antipsychotics, but it has also muscarinic and adrenergic antagonism and a glutamatergic agonist on top, which is possibly the reason why it is effective on cognitive deficits. Clozapine is purely metabolized by the liver by the cytochrome P450 family of enzymes, and it is metabolized into two main molecules, the clozapine N-oxide and N-desmethylclozapine. N-desmethylclozapine is also better known as norclozapine, and it presents a different pharmacodynamic compared to the parent compound, as it is an agonist, a dopaminergic and muscarinic receptors instead of being an antagonist. So it is unclear whether the role of clozapine on cognition is due to an MDA agonism or due to the action of norclozapine. Clozapine, as Professor Cavallaro said previously, is of extreme importance in schizophrenia, as it is the only available and approved treatment for pharmacoresistance. Treatment-resistant schizophrenia is defined by the TRIP working group consensus as the remaining of positive symptoms even after 2 lines of different antipsychotic medications with adequate adherence and dosage. Treatment resistance is a major public health challenge as it impacts the functional outcome. It brings lower quality of life and higher social dysfunction in these patients that moreover present more severe and more generalized, even more generalized cognitive deficits compared to their responder peers. Unfortunately, 40% of patients also do not respond to clozapine. These patients are known as ultra-treatment resistant, and the reason why the percentage is so high is probably due to a misuse of the drug clozapine. In fact, in often cases, the physician stops the treatment or the patient self stops the treatment before reaching an actual efficacy, or the dosage given is too low, and therefore the plasmatic levels of clozapine remain below the effective threshold. So in order to try and reduce the percentage of treatment resistance and to optimize the pharmacological treatment with clozapine, a useful element that would be taken into consideration is the clozapine to norclozapine ratio due to their agonist and antagonism interplay. And preliminary findings found the clozapine to norclozapine ratio is associated to cognitive function, to clinical outcome, and also to pharmacological tolerability and metabolic tolerability as well. However, those findings, those studies were conflicting in results and presented many issues. First of all, they had very small sample of patients, around the 20s. Moreover, they did not take into consideration the role of clozapine response, only opting for clozapine monotherapy and not taking into consideration ultra-treatment resistant patients. And finally, they didn't take into consideration possible influencing factors for the ratio, such as the smoking status. For this reason, our aim of the study was to evaluate the influence of clozapine to norclozapine ratio on cognition, on clinical severity, and metabolic tolerability among TRS patients treated with clozapine. And the hypothesis was that clozapine to norclozapine ratio could represent a predictor of treatment outcome. The study was conducted on 53 patients diagnosed with schizophrenia according to DSM-5 criteria. All patients were treatment resistant, 27 were clozapine responders, and 26 were ultra-treatment resistant. The disease severity was assessed through the Clinical Global Impression Scale for schizophrenia, the cognitive performance to the brief assessment of cognition in schizophrenia, the quality of life through the quality of life scale. Regarding statistical analysis, we ran multiple Pearson correlation as well as analysis of variance, so ANOVA, and a general regression model stepwise backwards. In this slide, you may find information relating to the sample we had during this study. On the left, you may find information regarding the clinical and demographic characteristic. On the bottom right, the mean scores of the patient, ABACS and QLS. And of notable importance, on the top right, we find the data regarding the clozapine-non-clozapine ratio and the clozapine related to the dosage and the clozapine related to the dosage. It is important to notice that our mean value of the clozapine-non-clozapine ratio was a 1.92, that according to literature, since it is slightly below 2, is considered an optimal value for treatment efficacy. So the Pearson correlation for the continuous variables noted significant positive correlations between the clozapine to non-clozapine ratio and working memory, between the clozapine dosage and disease severity, and the plasmatic levels of norclozapine and disease severity, and also found a significant inverse correlation between the plasmatic levels of norclozapine and the QLS. When we investigated possible influencing factors, we found that gender, age, and metabolic status were not influencing neither the ratio, nor the dosage, nor the plasmatic levels of clozapine and norclozapine. However, we did find a significant inverse correlation between the systolic blood pressure and the plasmatic levels of clozapine. Specifically, higher plasmatic levels of clozapine correlated with hypotension, as according to known literature. ANOVA showed that smoke has a significant effect on both the dosage and the clozapine to norclozapine ratio. In fact, non-smokers presented lower dosages but higher ratios. Also, we investigated through ANOVA the relationship between the clozapine response, so on the clozapine responder versus ultra resistant status, and the clozapine-norclozapine ratio, and did find a positive, significant association. In fact, patients that were ultra treatment resistant presented the lower ratios. To better understand the previous Pearson correlation results, we ran them on a general regression model. The first GRM was on working memory and resulted significant with a positive correlation for the clozapine-norclozapine ratio. The second GRM was instead on disease severity expressed through CGI scores, and it was also significant. In fact, lower scores, so lower disease severity, correlated with higher ratios. Also, gender resulted a significant regressor. In fact, male patients resulted more severe. The third GRM on QLS, so on the quality of life, resulted insignificant. In conclusion, our study did confirm the efficacy of clozapine to norclozapine ratio as an influencing factor over the cognition, over clinical severity, and also over therapy response among TRS patients treated with clozapine. Higher clozapine to norclozapine ratio in our study resulted associated with better working memory, better quality of life, better clozapine response, and better clinical status. This brings us to some very important clinical implications. First of all, we were able to give a contribution in explaining the mechanism of action of clozapine that is still pretty unclear. Through our study, we would be able to observe that there needs to be an important balance between the metabolite and the parent compound, as too much dopaminergic antagonism would cause sedation and therefore worsen cognitive symptoms, and too much of agonism instead would cause an increase in positive symptoms and on cognitive deficits as well. Moreover, we were able to observe that probably it is the glutamate action of agonism action of clozapine that has a major importance, and therefore the ratio should be skewed toward clozapine and not clozapine. Moreover, we indicate that the ratio is a possible predictor of treatment response in TRS and as a possible marker of cognitive function during clozapine treatment. Finally, we indicated a possible personalization of treatment in schizophrenia, as patients with lower ratios could be targeted for greater need of procognitive intervention as well as clinical and behavioral strategies aimed at increasing that ratio. The study was preliminary, so we have several limitations, but they also represented possible future perspectives. First of all, the study should be replicated in a larger sample, as well as it would be interesting to add neurobiological correlates such as neuroimaging and genetic studies to have a better investigation and understanding of the results. as well as doing longitudinal prospective studies to have a thorough comprehension of the clozapine to clozapine ratio and its meaning. And it will be of interest also to add to the study the involvement of other possible influencing factors, for example, kidney or liver function. And I would like to thank you all for your attention, and especially the disease unit for psychotic disorder, Ospedale San Raffaele, Professor Roberto Cavallaro and Dr. Marco Spangaro that mentored and taught me during all these years.
Thank you. I've gone to the exposition and final question.
I think that the best person to do some questions about this is the assistant supervisor, Dr. Marco Spangaro. I just wanted to comment that we are at the beginning of this kind of study, and we did already, Dr. Spangaro did already some studies also well published on the genetic influence on cognition with the polymorphisms of active functional polymorphisms of glutamate transporters and COMT metabolism. I think that the future will be to cross the data and explain why your data are different from those of the literature that I've available up to now, even if your explanation are absolutely believable. So please, Dr. Spangaro.
First of all, congratulations, Barbara. Beatrice, sorry. And first question. You were talking about earlier about strategies aimed to change the ratio among patients treated with clozapine in order to increase or reduce the impact of other maybe drugs or behavioral strategies. So what were you referring to specifically?
Yes, so as I said previously, clozapine is metabolized through the cytochrome P50 family of enzymes, but especially by CYP1A2. So the main strategy would be to do co-treatment and exploit the action of the cytochrome P1A2 by using inhibitors of the cytochrome in order to increase the plasmatic levels of clozapine, so the available clozapine, while keeping lower dosages and therefore maintaining the same efficacy, but lowering the possible side effects. According to literature, the most probable and the most important interaction would be association between fluvoxamine, so an SSRI, and clozapine, because other SSRIs are mainly focused on cytochrome P384, while fluvoxamine is an extreme inhibitor of cytochrome P1A2, and in fact, according to studies, has been found to increase the plasmatic levels of clozapine up to 10 times. So the proposed strategy, according to literature, would be to do a concomitant therapy between fluvoxamine and low dosages of clozapine. It would be obviously also important for the physician to take into consideration possible inducers of the cytochrome P1A2, since they are drugs, they are mostly anti-epileptics, and they are drugs that are commonly used in the clinical days. For example, carbamazepine and valproate are inducers of CYP1A2, and they decrease the plasmatic levels of clozapine, increasing possibly, since it is associated to that, the psychiatric condition and the positive symptoms, and also therefore the cognitive deficits. So when possible, it would be important to switch classes, maybe opting for an anti-epileptic that doesn't focus so much on the cytochrome 1A2, or if it's not possible, to increase the dosage and to monitor much more through blood exams of patients.
Okay.
Sorry.
Thank you very much.
Thank you. And stay with us, because at the end of the 3 candidates, we will do the proclamation. Stay with us, and then we come back as soon as possible.
Okay.
Okay?
Stay tuned.
Yes. Okay. Shall I remain in the call, or should I leave and follow the YouTube presentation and then come back?
Stay connected, I think.
Stay connected.
Yes.
Okay.
And then we come back for the proclamation later. Okay?
Okay, thank you.
And congratulations, Mrs. Barbara.
Thank you.
Perché adesso è un po' più difficile da dire. Grazie. La presentazione oppure fai la domanda dopo? Okay. Yes. Okay. Can you switch on the camera, please, Umar? Okay.
Yes. Hello.
That's it. Now we are moving to dermatology with the final destination, the dissertation of Rohit Quinn Kumar. The title of the work is Uveal Melanoma in the Eruptive Cherry Angioma, More Than a Simple Association. This is with Professor Mercuri and with Assistant Supervisor Dr. Giovanni Paolino is presented the candidate, please.
Thank you. It's a pleasure to introduce Rohit. We're in our population clinic of animal patients that we follow together with oncology. And in a little percentage of our patients, there are also patients with uveal melanoma that we follow together with the Department of Ophthalmology. And present evidence is found a very important distinction between cutaneous melanoma and eruptive cherry angioma. And so we decided to investigate also a correlation with a Laurea disease that is uveal melanoma. And we're with the performance research. So, Rohit, please.
Okay, thank you, Dr. Paolino. I'm just going to upload the PowerPoint, sorry.
Okay, that's perfect.
Sorry, it's
we can see the presentation. It's okay.
Okay. So thank you all for your attendance. My name is Rohit Quinn Kumar. My thesis is titled Uveal Melanoma and Eruptive Cherry Angioma, More Than a Simple Association, and it was undertaken in the Department of Dermatology under my supervisor, Professor Mercuri, and co-supervisor, Dr. Paolino. So, okay, there's a bit of a lag. I'm very, very sorry. So, what is uveal melanoma? Firstly, uveal melanoma, it's a cancer of the eye, specifically involving the vascular middle layer, the uvea, which is made up of the iris, the ciliary body, and the choroid. There is a proliferation of atypical melanocytes which appear in the uveal tract, which then goes on to form a uveal melanoma. It is the most common primary ocular cancer in adults, and its classification is based upon its location. That is, anteriorly consisting of iris melanoma and posteriorly consisting of choroidal melanoma and ciliary body uveal melanoma. In terms of epidemiology, I apologize for the Windows 95 graphics. that's going to come. I found data from a really large study of 84,000 patients, and I had put it into pie charts to better conceptualize the data. So in the first figure, we have the percentages of melanoma that were cutaneous, ocular, mucosal, and unknown primaries. So of this 84,346 patient study of cutaneous and non-cutaneous melanomas diagnosed in a 9-year period from 1985 to 1994, 91% were cutaneous melanomas, 5.2% were ocular melanomas, 1.3% were mucosal melanomas, and 2.2% were unknown primaries. Of this statistic, we can see on figure 2, the percentages of ocular melanomas. So from this study, we could deduce, with a further look into it, that of those ocular melanomas, 85% were uveal melanomas, so the most common type. 5% were conjunctival, and 10% occurred at other sites. For the purpose of this thesis, I'm talking strictly about uveal melanomas. Again, of this statistic, we could further deduce the distribution of the different types of uveal melanoma that were found to be choroidal melanoma, ciliary body melanoma, and iris melanoma, with choroidal melanoma being the most common, representing 90%, followed by ciliary body at 6% and iris melanoma at 4%. Furthermore, in terms of additional epidemiology, studies have shown that there is a greater incidence found in higher latitudinal countries such as Norway and Denmark compared to the lower latitudinal countries such as Spain and Italy. This difference could be related to the protective effects of ocular pigmentation in the southern population with greater uveal exposure at lower latitudes. According to SEER data, uveal melanoma is more common in the white Caucasian population. An analysis of this data from the year 1992 to the year 2000 had shown that out of 1,300 melanomas studied, the annual age-adjusted incidence per million was 0.31 in the black population, 0.38 in the Asian and Pacific Islanders, 1.67 in the Hispanics, and 6.2 in non-Hispanic whites. Incidentally, although uveal melanoma is rare in the Asian population, it has been observed that the age of incidence of uveal melanoma is lower compared to the white population. Also, rarity of uveal melanoma in the black population can be contributed to the protective effects associated with dark skin pigmentation. Uveal melanoma is commonly seen in the older population, around 60 years of age being the average age of initial diagnosis, and also pediatric cases are rare, with several studies observing only 0.5 to 1.3% being 20 years of age or younger. There's an equal incidence in both sexes, so male and female. And moving on to the associated risk factors. So here we have a list with the associated risk factors, age being a risk factor, as a higher incidence of uveal melanoma is found in the older population. And host susceptibility factors for uveal melanoma include fair skin, blonde hair, light eyes, so blue eyes, and the inability to tan. This could be related to the fact that there is less melanin present in the choroid and retinal pigment epithelium, which results in less protection from ultraviolet light and thus increased risk of developing uveal melanoma. Uveal melanoma is more common in people who sunburn easily, and so that's a Fitzpatrick skin type 1 and type 2, so quite pale with quite fair skin. It has also been reported that patients with atypical cutaneous nevi are 4 to 10 times more likely to develop ocular melanoma. Another risk factor is oculodermal melanocytosis, which is a congenital pigmentary abnormality of the episclera and the uvea, affecting blacks and Asians more than the white population. It is thought that the increased number of melanocytes in the uveal tract predisposes patients to uveal melanoma, as shown by the likelihood of developing tumors in areas affected by melanocytosis. Occupational exposure to certain types of radiation, there have been numerous studies. One particular one was arc welders. Welding includes visible and infrared radiation and frequently occurs with chemical exposure, and chemical exposures to such chemicals as asbestos, antifreeze, formaldehyde, and pesticides are known associated risk factors. In addition to this, the Cancer Genome Atlas project had identified rare germline mutations in several different cancer genes, with BAP1, BRCA1 associated protein 1, showing a strong association with the predisposition of uveal melanoma. Lastly, which everyone was probably thinking, ultraviolet radiation. So UV radiation is thought to be an associated risk factor for uveal melanoma. However, literature on the topic of sunlight exposure and occurrence of uveal melanoma is contradictory, suggesting that chronic ultraviolet light exposure is an independent risk factor for uveal melanoma. A recent meta-analysis covering all published reports of UV light exposure, uveal melanoma, demonstrated that chronic ultraviolet light exposure, occupational sunlight exposure, and outdoor leisure sunlight exposure played a minimally significant role in development of uveal melanoma. So that was a little background on uveal melanoma. I will now go on to speak about cherry angiomas. Okay. So cherry angiomas, also known as senile angiomas, Campbell-De Morgan spots, they're the most commonly acquired cutaneous vascular proliferation. They're very common in the elderly, again around 60 years of age, and it affects both sexes equally. However, there is an unknown cause. Genetic analysis had found cherry angiomas to harbor a missense mutation in the G proteins GNAC and GNA11 genes, which are involved in other melanocytic proliferations, such as uveal melanoma, cutaneous melanoma, and non-uveal melanoma. On the next slide, we have some more important clinical features of cherry angiomas that I think is very important to have a look at. So a few clinical features of the cherry angiomas, if you can look at image 2, the top left, they are usually round, oval in shape. And now looking at image 3, that's a dermoscopic view of a red cherry angioma. The black arrows, I don't know if you can see that, point to multiple red lacunae or lagoons, which are the hallmark of cherry angiomas. And underneath, we have a blackish, bluish sort of cherry angioma, which is another color it can exist in. And again, the arrows pointing to the lacunae. Lastly, in image 5, so bottom left, we can see a traumatized angioma. And also, they're mostly presenting on the trunk, so it's very rare to find it on the distal extremities. Taking a further look at this, I'm going to just explain about the dermoscopic views and also the histological views. So with the dermoscope, a dermatologist's main tool, it consists of a magnifier, typically times 10, a non-polarized light source, and a transparent plate and a liquid medium between the instrument and the skin, which allows the inspection of skin lesions with an unobstructed view from skin surface reflections. As you can see from image 6 and image 7, which are dermoscopic views, you can really see lacunae, which are really well demarcated. It's also it's round to oval, and the colors red, reddish brown, also reddish blue, as we've seen. And they vary in size and color within a given lesion. Lacunae may be either tightly clustered or they may be loosely scattered throughout the lesion, and they are often located on a background, again, like a red bluish or red-white homogeneous color. Occasionally, individual dilated blood vessels or a red network of vessels may be visible. Hemangiomas may also develop partial thrombosis or full thrombosis, and it will acquire a dark color, focal blue-black color, or completely black in color. Moving over to the right, we can see a histological examination of cherryangiomas, which shows true capillary hemangiomas. So the findings of this show a thin epidermis and numerous newly formed capillaries with narrow lumens and prominent endothelial cells arranged in a lobular pattern in the papillary dermis underneath the epidermis. Also, treatment of cherryangiomas is only necessary for patients who are bothered by lesions, so more often than not cosmetic reasons. Patients should be advised, however, that new lesions are likely to develop and there is no known way to prevent them. Small lesions can be electrocauterized after local anesthesia, so 1% lidocaine. Shave excision and electrocauterization is often used at the base, which is useful for larger lesions. Cryotherapy or laser therapy can also be used to remove superficial lesions. So after a little background now, we're going to move on to the association. So the association between our study initially came from this idea, and this was the initial idea. And these studies had shown the association between cherryangiomas and cutaneous melanoma. So in these two recently published articles, the first paper on the left, the association between eruptive cherryangiomas and malignant melanoma, a cohort of 1,693 patients was observed. It was looked at with age, gender, cutaneous, non-cutaneous malignancies, immunosuppressive treatments, and the presence of cherryangiomas were recorded. The results had shown that 804 out of the total patients had eruptive cherryangiomas, so roughly 48%. The association between malignant melanoma and eruptive cherryangiomas was highly significant in patients less than 50 years of age, and significant in 51 to 70 years of age, and after the age of 70, with non-significant results. Similarly, in the second study on the right, in a cohort of 1,190 patients over a 5-month period with, again, age, gender, cutaneous, non-cutaneous malignancies, the presence of cherryangiomas were also recorded, and results had shown eruptive cherryangiomas in patients less than 70 years of age were significantly associated with malignant melanoma. In addition, having more than 2 atypical melanocytic nevi in patients greater than 50 years of age was also significantly associated with malignant melanoma. These results confirm the associations between malignant melanoma and eruptive cherryangiomas, as well as the association between malignant melanoma and having more than 2 atypical melanocytic nevi. With these studies combined, the idea for our study was conceptualized, that is there an association between uveal melanoma and eruptive cherryangiomas? So, from the 2 previously mentioned articles and with an additional article, we have combined references and used the cutoff values corresponding to cherryangiomas. When cherryangiomas were greater than 10 in number, they were known as eruptive. In addition, using the study, a correlation of serum tryptase levels with total number of nevi, Breslow thickness, ulceration, and mitotic index in melanoma patients, the title article, which I put the abstract on top right. The total number of nevi was assessed using a dichotomous scale of less than or equal to 10 or more than 10 in number. So, the aim of our project, our aim was to better understand the strength of the association between uveal melanoma and eruptive cherryangiomas. For the material and methods, our study was carried out at the oncodermatology department in San Raffaele, together with the Department of Ophthalmology, also at San Raffaele Hospital. It was an observational monocentric study with 33 patients in total with uveal melanoma diagnosed at San Raffaele Hospital, and the enrolled patients subsequently examined for cherry angiomas also at the San Raffaele Hospital. As mentioned previously, the cutoff values for cherry angiomas were greater than 10, labeled as eruptive cherry angiomas, and total number of nevi recorded as less than or equal to 10 and greater than 10 in number. All patients were above the age of 18. They were diagnosed with uveal melanoma. Personal and familiar history were collected, and also the history of metastasis in the previous 5 years was specifically inquired, as well as having other diseases. It was tested with a logistic regression with odds ratio reported for each association. So moving on to the results, we have two box plot graphs here, graph A on the left and graph B on the right. So from the total patient cohort, our study consisted of 17 females, 52%, and 16 males, 48%. As shown in figure A on the left, the correlation between eruptive cherry angiomas, labeled ECAs, and uveal melanoma, labeled UM, were present in 21 patients, which was 63% of the whole uveal melanoma population sample. On the right, the median age of the patients with uveal melanoma, UM, and eruptive cherry angiomas, ECAs, was slightly lower at 63 years old in comparison to the median age of patients with uveal melanoma and no eruptive cherry angiomas at 66 years old. Even though the means were similar between the two groups, so 63 years old plus minus 9.9 years for the patients with uveal melanoma and eruptive cherry angiomas versus 64 years of age plus minus 12.3 for the patients with uveal melanoma but no eruptive cherry angiomas. So now we have figure C. On this graph, comparing the total number of nevi TN with eruptive cherry angiomas, ECAs, and non-ECAs, non-eruptive cherry angiomas. 16 patients in total had a total number of nevi more than 10. The proportion of patients with a total number of nevi greater than 10 was higher in patients with uveal melanoma and no eruptive cherry angiomas than patients with both uveal melanoma and eruptive cherry angiomas, with a p-value of 0.005, a significant value. So moving on to this next graph. In 17 patients, so 51%, a positive familiar history for malignancies was recorded, with no differences between the groups, 0.3. The percentage of patients with uveal melanoma, UM, and eruptive cherry angiomas, ECAs, with systemic comorbidities was lower than compared with the percentage of patients with uveal melanoma and no eruptive cherry angiomas, p 0.005, again, significant value. 4 patients from the entire uveal melanoma cohort had a history of distant metastasis in the previous 5-year period. All of the metastatic patients were patients with uveal melanoma and eruptive cherry angiomas, representing 19%. There were no cases of patients with uveal melanoma metastasis reported in the non-eruptive cherry angioma group. 1 patient had died 9 months after the hospital visitation, and also 16 patients reported other diseases, which consisted of 3 cases of diabetes, 7 cases of hypertension, 1 history of myocardial infarction, 1 case of lupus erythematosus, 1 case of glaucoma and psoriasis, another case of polycythemia, 1 case of thyroiditis, and 1 case of hypercholesterolemia. So, compared with the association between eruptive cherry angiomas and cutaneous melanomas, which has been well established, in regards to our study, etiology and pathogenesis of cherry angiomas has not yet been fully elucidated. Possible inducers or considered predisposing factors for the development of cherry angiomas, such as chemicals, immunosuppression, chronic graft versus host disease, lymphoproliferative diseases, HHA, and downregulation of MER44 seem to be a possible inducer in regards to current literature. Another key point to mention is the role of angiogenesis. So that's a pivotal event in the growth of eruptive cherryangiomas and neoplasms, including uveal melanoma. Vascular endothelial growth factor, VEGF, and basic fibroblast growth factor play key roles in angiogenesis in uveal melanoma. Both VEGF and fibroblast growth factor are necessary for the proliferation of cherryangiomas as well. Also, tumors with a high vascularity index carry a greater risk of metastasis and a poor prognostic outcome. We had found in our study patients with metastatic disease fell into the category of uveal melanoma with eruptive cherryangiomas. So, in conclusion, 21 out of 33 patients diagnosed with uveal melanoma also had eruptive cherryangiomas, equating to 63%, a prevalence apparently higher compared to the global population, which ranges between 41 and 48%. Eruptive cherryangiomas tend to appear around 50 years of age and increase in number thereafter. This could explain the relatively high incidence of eruptive cherryangiomas in our uveal melanoma sample. Patients with uveal melanoma and eruptive cherryangiomas were younger than patients with uveal melanoma alone, and this could suggest a potential association between the two lesions. A lower total number of nevi were found in patients with uveal melanoma and eruptive cherryangiomas. And I would also like to say we acknowledge the small sample size of a total of 33 patients. But given that uveal melanoma is a rare malignancy, it might be hard to collect larger samples in single-center studies. In addition, we did not find any association between eruptive cherryangiomas and other cutaneous or extracutaneous malignancies. However, it was a small sample, so bear that in mind. So, what next? Our findings suggest a possible clinical association between eruptive cherryangiomas and uveal melanomas. Further studies are needed to validate this association, possibly a larger cohort of patients, a multicentric study too, and this could lead to the possibility of ocular screening, which could be recommended to patients bearing a high number of eruptive cherryangiomas. I would just like to thank everyone who participated in the study, the departments of ophthalmology, oncology, pathology, and dermatology, and to all of the staff at San Rafael University and also the hospital. Again, thank you all. Thank you for listening. Okay. If you have any questions or...
Thank you for your presentation, and now some questions. Yes, Dr. Farid.
It's a big thing that it should be important expand the sample size, because we know that people are very rare. And so our was a long-term study. It was very difficult to collect 33 patients. And we think that the study should be studied maybe for screening. They should be performed also in patients with melanoma and patients with diffuse melanoma.
Sorry, could you just repeat the last part of the question, please? The connection was coming up a little bit.
I mean, according to your result, do you think that an ocular screening should be performed in patients with eruptive cherryangiomas?
Yes, I think with the way that there's no currently ocular screening for uveal melanoma, given the rarity of the disease, and it's often presented asymptomatically. And given if the study can be repeated and that the associations are further validated, I think ocular screening should be and could be recommended with the strength of the association. And dermatologists could work together and cooperate with ophthalmologists as well, and it could lead to better diagnostic outcomes and affecting treatment and prognosis in a positive way. Thank you.
Any other questions? Okay, thank you. And stay with us
Okay.
because we are doing the proclamation later at the end of the third candidate. Thank you.
Okay, thank you. Bye-bye.
C'è Yasui.
Can you stop the sharing, please? No. Adesso abbiamo Daisuke, vero? Daisuke, ok. Non abilitante.
No.
Penso di...
Adesso possiamo dare i due titoli completamente diversi. Uno abilitante e uno non abilitante.
Yasui,
Di questi
can you open the camera, please?
Yes.
Okay. Thank you. Good morning.
Good morning.
And now we are the new dissertation of Daisuke Yasui, Supervisor Professoressa Codazzi, Assistant Supervisor Daniele Zacchetti, and the title is Follow-up of the Effect of Direct Post-Translational Modification of Astrocytic Connexin 43. Present the candidate of...
Works about Daisuke did some experimental work on microsystems, but unfortunately he had to work on Japan because of the COVID. So he did anyway an experimental work on the role of connexins on astrocytes, and I think that his work is going along that very specific line. He's try to understand whether there is a, let's say, space for pharmacological intervention using connexins as a target in several diseases, especially in the nervous system. So, please, basically, you can start your presentation.
Okay. Okay, thank you, Professor Zacchetti, for introducing me. And now I would like to start my presentation on my thesis, follow up on the effect of direct post-translational modification of astrocytic connexin 43. Before going into depths about astrocytic connexins, I will first give a quick review on gap junctions. A gap junction is formed by two hemichannels docking to its counterpart on the opposed cell. Each of these hemichannels are called connexons. Each connexon hemichannel consists of 6 protein subunits termed connexins. The predominant connexin isoform of astrocytes is connexin 43, which is the main connexin we will cover today, but the other isoforms such as connexin 26 and 30 are also present on astrocytes. Now I will briefly introduce the complex gap junction network in the brain. Astrocytes are the most abundant cells in the central nervous system, and they are critical for synaptic transmission and homeostasis maintenance. One of the main mechanisms by which astrocytes achieve this function is via the network formed by gap junctions, as you can see in this figure. Along with the ionic buffering and adhesion to nearby cells, modification of neuronal excitability is an important function of gap junctions. As you can see here, astrocytes can form gap junctions between themselves and with oligodendrocytes. Although the function of this oligodendrocyte-astrocyte gap junction is not characterized well, we know that this gap junction is downregulated in some cancers, such as gastric cancer. Another thing to note here is that not only the gap junctions, but the hemichannels have a function too, such as regulation of synaptic plasticity and feedback inhibition. Now that we have reviewed some of the basic concepts and terminology, I will talk about how connexins have an impact in diseases. Here are some diseases in which connexins have connexin 43 alteration is known to happen. In the case of Alzheimer's disease, the expression of connexin 43 in astrocytic gap junctions is upregulated in the cortical regions of amyloid beta plaques. On the other hand, a decrease in the expression of connexin 43 and connexin 30 was also found in newly formed plaques. So depending on the time point of the disease, the expression pattern of connexin 43 changes. And brain ischemia is a leading cause of long-term disability or even mortality in adults. Accumulating evidence suggests that astrocytic connexin 43 expression is increased after hypoxia ischemia injury, and that connexin 43 plays an important role in cell death and neuronal damage induced by cerebral ischemia. In the case of astrocytic brain tumors, 2 independent studies reported that connexin 43 protein expression decreased with increasing tumor grade. A group noted a decrease in connexin 43 expression from 100% in grade 1 glioma to 14.3% in grade 4 glioma, suggesting that the loss of functional connexin 43 results in more malignant phenotypes. Another group also reported that connexin 43 protein expression decreased in grade 3 and 4 tumors. But interestingly, they reported that connexin 43 mRNA levels remained high. From this data, we suspected that post-translational modification of connexin 43 may play an essential role in disease progression in different conditions. As I mentioned briefly, there are many diseases in which we know that there are alterations in connexin 43 expression, but nobody really knows the relevance of these changes. Moreover, little is known about the relevance of changes in expression versus post-translational modification. To have a better understanding of what is going on at a molecular level, we chose a drug to better characterize the molecular alteration. And since pioneering studies showed that propofol, a general anesthetic, can inhibit astrocytic gap junctions, in our study, we chose propofol. After the characterization of the molecular alteration, another goal for us was to determine whether this modification was a direct effect of propofol or an indirect effect resulting from the inhibition of neuronal activity. In our experiment, we used acute cortical slices of 14 to 21-day-old mice. We lysed some samples using Triton. The aim of this was to separate connexin 43 in the plasma membrane from connexin 43 that wasn't. With this separation, we can distinguish between functional and non-functional connexin 43, since, as I mentioned in the beginning, both the hemichannels and gap junctions are functional. For the initial experiment, we used a polyclonal rabbit antibody against connexin 43 as a primary antibody. The non-DRM portion is non-functional connexin 43, and the DRM portion is the functional connexin 43. In this experiment, we demonstrated that propofol does not change overall connexin 43 expression, as you can see here. But we also found that propofol changes the migration pattern on a gel in the membrane-bound portion of connexin 43. As you can see in this figure, the high-density portion of the band for DRM in propofol-treated slices are higher than in control slices. You can also notice that the band in the functional group is much narrower in the propofol-treated group. To quantify this data, we analyzed the intensity of the bands, and you can easily visualize that the intensity of profile showed a steeper spike on the propofol-treated slices compared to the control slices in the DRM portion. Since there was a shift towards the higher molecular weight region, we suspected that this change was a result of phosphorylation. Phosphorylation of serine at position 368 is the best characterized phosphorylation site of connexin 43 and is known to reduce gap junction permeability. We therefore analyzed the propofol-treated cortical slices with a polyclonal rabbit antibody specific for connexin 43 phosphorylated at serine 368 to see if the migration pattern alteration was indeed caused by phosphorylation at this site. As you can see in these two bottom graphs, results showed that propofol treatment increased connexin 43 phosphorylation at serine 368 in the non-DRM and DRM groups. The results also indicate that phosphorylation does not promote changes in the portion of non-DRM versus DRM fractions of connexin 43. The next step was to determine if this connexin 43 phosphorylation was a direct effect of propofol or not. We applied a voltage-gated sodium channel blocker, tetrodotoxin, TTX, to examine the effect of propofol in the presence of neuronal activity blockage. In hindsight, we should have conducted the study with better positive and negative controls. For example, a negative control without tetrodotoxin and a positive control here with only propofol and without tetrodotoxin. And since propofol already inhibits neuronal activity, instead of using TTX, we could also use molecules such as bicuculline to see if propofol induces phosphorylation in the event of enhanced neuronal activity in the future. That being said, TTX did not change the expression levels of connexin 43 in the non-DRM or DRM fractions. But as you can see on the Western blot and the graph on here, even when TTX was applied, the phosphorylation of connexin 43 at serine 368 in the DRM group was increased significantly. So even in the event of blocked neuronal transmission, propofol was able to phosphorylate functional connexin 43. So we concluded that the phosphorylation of connexin 43 at serine 368 was in fact a direct effect of propofol. This experiment left us with several questions that we hope to follow up on. The first question is, are there also any changes in phosphorylation status of other connexin 43 phosphorylation sites, such as serine 282, which is also known to reduce gap junction permeability? The second is this effect specific to propofol, or is it a general mechanism by anesthetics in general? Lastly, what is the overall impact of this phosphorylation and reduced permeability on a tissue level? This last point is very difficult to evaluate, hence the dynamic activity of connexin 43 and the fact that cell cultures do not resemble the morphology of gap junction networks. Therefore, we need to identify techniques to monitor connexin 43 in vivo. And as of today, the dynamics of connexin 43 cannot be visual directly, but by following the flow of interstitial fluid, there may be a possibility to monitor the function of gap junctions indirectly. And this could provide information on the dynamics of connexin 43. There are two possibilities to do this. First, to follow the flow of interstitial fluid at a macro level. And to do this, we can use MRI with a 17O-H2O tracer. This will help identify the impact of connexin modification at tissue level. The second is to follow the flow of interstitial fluid at a micro level by using coherent anti-Stokes Raman scattering microscopy. This will help link the functionality of connexin 43 and the impact on its microenvironment. Both of these techniques have already been implemented in the brain of animal models to follow the activity of aquaporins and its impact on the permeability of the blood-brain barrier. Therefore, we may be able to integrate these technologies to monitor connexin dynamics as well. Since gap junctions can play a relevant role in several diseases at different stages, including the ones that I've mentioned in this presentation, identifying the details of their activity and modulation by several molecules could lead to the introduction of new therapeutics to the field of the pharmacology of connexins. Thank you. And before I finish, I would like to give a special thanks to Professor Kodazzi and Professor Zacchetti who have helped me throughout these 2 years. Professor Nuria and Professor Yasui of Keio University for helping me perform all the experiments. And finally, a special thanks to the secretary and staff of UniSR for helping this day happen in the middle of a pandemic.
Thank you, Mr. Daisuke. Congratulations. Any questions?
I have a couple of questions. The first is a curiosity, is about the effect of a neuroinflammation on connexin 43 expression. I mean, in the introduction of your thesis, you suggested that in the Alzheimer's disease, for instance, the neuroinflammation can affect the expression. I'd like to have a comment about this, both in culture or in vivo if there are some data about this effect.
So we couldn't really follow up on the effect here, but there are some in cancer metastasis. There's also an upregulation of connexin 43. So we know that these things happen, but as I mentioned in the conclusion part, we don't really have any ways of monitoring this activity in vivo. So it's very hard to characterize what is really going on.
There are some data in vitro on resting or activated astrocytes.
At a cell culture level, no. I couldn't find anything at the moment, but they were just telling this as like a upregulation, downregulation in certain diseases.
Okay, so the second question was about the effect of phosphorylation on gap junction permeability. Mm-hmm. Because yes, I mean, this can be a very important functional aspect of your data, but no references are in the thesis about this. I mean, if you can comment this aspect. So the effect of phosphorylation on gap junction permeability.
Yes, so there are, including the phosphorylation site that I've mentioned right now, there are other phosphorylation sites, and in general, this phosphorylation is known to decrease the permeability of gap junctions.
But in this case of serine, I don't remember, phosphorylation, is there any data about this specific phosphorylation?
Yes, in this case, it's known to decrease the permeability of gap junctions.
Thank you.
Thank you.
Okay, thank you. And another question.
A question maybe it's a bit provocative, but can we continue to use safety protocol for anesthesia in children? What about the clinical implication of your findings?
I'm sorry, I couldn't hear the beginning of your question.
Question is about the clinical use of propofol in children for sedation, for anesthesia. So, are these data in terms of safety still reassuring, despite, of course, your biological function, your biological finding?
So there are only a few molecules that we know that alter directly connexin functions. And so it's not really implemented into the clinical field yet. But in some of the studies not in children, but in cancers, we know that these molecules are able to increase the permeability to other chemotherapeutics as an indirect effect. So not only by this increase and decrease of gap junction expression, but it could have an indirect positive effect. So maybe yes, hopefully.
Thank you. Other questions? Okay, congratulations. And
thank you.
Stay with us, and then we will do the proclamation later. Okay?
Okay, thank you.
Okay.
Good morning.
Good morning. How are you?
I'm good, Professor. How are you?
That's perfect. And Mr. Schumann did a very interesting study about regenerative medicine and orthopedics, and we know that the last 10 years, many studies was produced in this field, and we are now finding the best solution for the best patient. And this study tried to understand if there are gender difference between treatment of this kind of treatment. In his study is doing a prospective study about ACS and BIMA, and we can see the difference in different kind of treatment. And he performed a very interesting study with Dr. Matteo Vitali. Please, you can show your study. Okay.
Yes.
You have to share the video.
Correct. Sorry. Can you see the slideshow?
Yeah, but you have to change in. Okay, that's perfect.
Okay. Thank you for the introduction, Professor Cellini, and good morning to the Commission. My name is Anshuman Chawla, the author of the thesis entitled Clinical and Functional Evaluation of Bone Marrow Aspirate Concentrate versus Autologous Conditioned Serum Intra-Articular Injections in the Treatment of Knee Osteoarthritis, a gender comparative study performed under the supervision of Professor Vincenzo Cellini and Assistant Supervisor Dr. Matteo Vitali. Knee osteoarthritis is a multifactorial degenerative joint disease resulting in chronic and often debilitating pain, as well as significant functional limitation. According to the World Health Organization Global Burden of Disease Project, the estimated global prevalence is 3.8%. It is believed that increased average life expectancy globally is responsible for the increasing incidence of this disease. As such, it is projected to become a massive burden on global health systems. Osteoarthritis results from a multifactorial etiology. Mechanical loading or post-traumatic deformity in the context of predisposing factors such as age and obesity result in cartilage degeneration, leading to pathological subchondral bone remodeling. Essentially, the breakdown products of meniscal and articular cartilage, such as collagen and proteoglycan, are phagocytosed by macrophages. Eventually, the phagocytic capacity of macrophages is overwhelmed, and release of inflammatory mediators such as interleukin 1, interleukin 2, interleukin 6, and tumor necrosis factor alpha promote an inflammatory cascade. Osteoarthritis can be broken down into two main treatment categories, the conservative options and the non-conservative options. Among the conservative, there are non-pharmacological and pharmacological options. The non-pharmacological options include diet, exercise, and orthoses. Diet, the goal being to reduce the axial load upon the joint by weight reduction. Exercise, to strengthen the often weakened quadriceps and hamstring muscles, and the use of orthoses to correct malalignment and shift the force. Within the pharmacological options, the mainstay of osteoarthritis treatment are the non-steroidal anti-inflammatory drugs based on their inhibition of COX-1 and COX-2, or the selective COX inhibitors that inhibit only COX-2. These were designed to reduce the pathological effects on the gastric mucosa, but they are also associated with potentially dangerous side effects. Next is the employment of steroid injections. These work by inhibiting NF-kappa beta, and that inhibits the transcription of signaling factors downstream, reducing inflammation. And lastly is hyaluronic acid, which is injected to provide lubrication to the joint. An interesting new field has emerged in recent years, regenerative medicine. Three potential therapies are platelet-rich plasma, autologous conditioned serum, mesenchymal stem cells, both bone marrow-derived and adipose tissue-derived. And lastly, on the right side of the algorithm are the non-conservative options, which are unicompartmental knee arthroplasty and total knee arthroplasty. Unicompartmental knee arthroplasty is recommended according to the Cozen and Scott criteria of 1989. However, this original criteria was highly restrictive, allowing for only 6 to 12% inclusion, so it was revised by the Oxford group. And total knee replacement is the end stage. It is also the gold standard of osteoarthritis treatment of the knee. So why did we perform this study? So while several regenerative therapies have shown promise, there is a gap in the literature comparing their clinical performance against one another. As such, this study focused on the comparative effectiveness of BMAC versus ACS in patients with early early stage knee osteoarthritis. On the left, in the inter-cohort series, you can see that the analysis was stratified by sex for the entire population, as well as within the individual cohorts to detect any gender differences and any gender-based differences. On the right, in the intra-cohort series, within the ACS and BMAC groups, we compared the clinical improvement in males versus females within each treatment class. Speaking a little bit about the two treatments that we compared. So first we have autologous conditioned serum. It is an aspirate of venous blood incubated on chromium sulfate glass beads for 7 hours at 37 degrees. Thereafter, it is divided into aliquots and stored at -20 degrees for use in the outpatient clinical setting. The series is 4 injections over 4 weeks in the outpatient clinical setting, and it is comprised of 3 main therapeutic components. The first being interleukin-1 receptor antagonist, followed by interleukin-4, interleukin-10, interleukin-13, and various growth factors. Primarily, interleukin-1 receptor antagonist is at play here. Incubation with the chromium sulfate-coated beads results in production of interleukin-1 receptor antagonist at an order of about 100 to 1,000 times higher than if it were to be incubated with regular glass. And the effect of this is modulation of inflammation. Next, we have bone marrow aspirate concentrate. It is a single injection series performed in the surgical setting and often coupled with a surgery. And it has various therapeutic components as well. Number 1 are mesenchymal stem cells, and number 2 are platelets, progenitor cells, lymphocytes, and granulocytes in varying proportions. The mesenchymal stem cells are a very fascinating component because they not only modulate inflammation, but they possess the ability to differentiate down the chondrocytic lineage, which allows for the potential regeneration of cartilage. And as you can see below, on the right, next to BMAC derived from bone marrow, is the Harvest Smart Prep kit that is used at San Raffaele Hospital. And moving on, how do we prepare these products? 60 milliliters are aspirated, 60 milliliters of bone marrow are aspirated from the anterior iliac crest and placed in a bag coated with anticoagulant and thereby filtered into a syringe. Moving on to step 3, it is inserted into a sterile disposable cup designed specifically for separation of these components, which occurs in step number 4, when it is incubated, where it is centrifuged at 2,800 RPMs for 15 minutes. Next, step number 5, the top fraction is removed, the plasma fraction. And step number 6, the bone marrow aspirate concentrate containing its higher proportion of mesenchymal stem cells is withdrawn into a syringe, transferred to the scrub nurse, and injected into the superolateral portal. ACS is a more simple procedure. It's simply aspiration of 50 to 60 mLs of venous blood, which are incubated, as I said, at 37 degrees for 7 hours, centrifuged and injected at a later date into the superolateral portal. So treatment effectiveness in our study was measured using 3 different clinical outcomes. On the left, you can see that we used the Western Ontario and McMaster University's Osteoarthritis Index, the WOMAC. We also used the Visual Analog Score and Range of Motion Assessment. The WOMAC is a 3-section questionnaire. The score is out of 96 points, which we then inverted and normalized to get a score out of 100, with 0 representing the worst and 100 representing the best. The Visual Analog Score, essentially, is a paper presented with a line on it, where the patient marks where they rate their pain. We used a modified version of the VAS, of the VAS, and we simply requested a verbal report of 0 to 10 scale, with 0 representing the best and 10 representing the worst. Range of motion assessment was measured with a goniometer, and it was defined as the difference between maximum extension, which is 0 degrees, and maximum flexion. Additionally, we paid attention to age, sex, knee laterality, and length of follow-up. The length of follow-up for BMAC was at time intervals of 1 month, 3 months, 6 months, and 1 year, whereas the time points for ACS were 1 month and 6 months. So moving on to our results, our mean length of follow-up was 6.6 months, and there were several interesting findings. First, the degree of improvement in the WOMAC score was significantly higher in the BMAC group. There was no statistical significance in VAS or ROM. In graph number 2, when stratified by sex, there was no difference in the amount of improvement for any of the outcome measures in males. In graph number 3, you can see that with our female patients, there was a significant difference in the amount of improvement with regards to the WOMAC. In graph number 4, stratifying only the BMAC patients by sex, female subjects were associated with a greater degree of improvement in both VAS and WOMAC compared to males. Lastly, in graph number 5, similar to our BMAC results, the ACS cohort females demonstrated a greater degree of improvement in both VAS and WOMAC compared to males. So what do we derive from all of this? The following conclusions. Patients treated with BMAC had a greater degree of improvement in the WOMAC compared to patients treated with ACS. Females treated with BMAC had a greater degree of improvement in the WOMAC compared to females treated with ACS. Females treated with BMAC have a greater degree of improvement in both WOMAC and VAS compared to males treated with BMAC. Females treated with ACS have a greater degree of improvement in both WOMAC and VAS compared to males treated with ACS. And lastly, no significant difference in ROM improvements were detected between treatments or genders. Moving on to our discussion, the results clearly indicate a female bias in improvement using both ACS and BMAC. So the following 2 mechanisms could potentially explain this. Number 1, mesenchymal stem cell concentration in bone marrow is inversely proportional to age. As patients age, the niche declines. This applies to our study because on average, our females were about 6 years younger than the males. This means they saved 6 years of telomere erosion, telomeres being the end sequences of DNA that with each successive division are shortened and eventually result in death of the cell. Additionally, it's less exposure to reactive oxygen species that cause the decline in the niche. The second proposed mechanism is there's a potential gender difference in the joint pain experience. According to studies by Pan et al., female knee osteoarthritis pain is driven by inflammatory mediators, such as evidenced by increased interleukin-1 receptor and increased interleukin-1 expression in the chondrocytes of females with knee osteoarthritis. Additionally, Contartese et al. Demonstrated that male knee osteoarthritis pain is driven by mechanical damage, as evidenced by the increased subchondral bone sclerosis and increased prevalence of bone marrow cysts in this population. This makes sense because one of the potential mechanisms for pain for knee osteoarthritis relates to the increase in interarticular pressure in the joint, which is usually at 2 to 10 millimeters of mercury, but with bone marrow cysts can rise as high as 20 millimeters of mercury, which then stimulate mechanoreceptors and signal a pain transmission. Next, our study had various strengths. Outcome measures were well validated in the literature, meaning the WOMAC, the VAS, and knee range of motion. These are very common measurements for knee osteoarthritis. Additionally, we had the advantage of single center consistency, meaning our protocols were standardized and we had very little intraoperative and procedural variation. Lastly, this is the first sex-stratified study of outcomes for these treatments. Our study was not without limitations. We have a lack of randomization, which makes us prone to bias. We used a small sample size, increasing our risk for making a type 2 error. And we only evaluated short-term outcomes with a maximum time period of 1 year. We believe that future studies should employ MRI as an objective evaluation to complement our subjective patient-reported measures. MRI would be useful because, especially in the case of BMAC, if there's a regenerative capacity, you can see an increase in the bone in the cartilage thickness and an increase in the joint space. Additionally, we believe further studies should use randomization and consider long-term follow-ups. And lastly, and most interestingly, is I believe a comparison should be done between adipose-derived stem cells, ADSC, versus our product used in this study, BMAC. This is because in adipose-derived stem cells, there's not as much of a decline. In fact, there's a very little decline in the niche of the population of mesenchymal stem cells. And this could be a potential therapeutic consideration. I would like to acknowledge Professor Vincenzo Cellini for giving me the honor of doing this research under his supervision. I would also like to thank Dr. Matteo Vitali for providing me with 3 years of incredible clinical and research experience under his tutelage. I would also like to thank Dr. Marco Ometti, Dr. Pierluigi Peronti, Dr. Alice Sandrucci, Orlando Leone, and the entire Department of Orthopedics and Traumatology at San Raffaele Hospital. Here are a few of the departmental collaborations I was very fortunate enough to gain experience and contribute to under the supervision of Dr. Matteo Vitali. Thank you, and I am ready for questions.
Thank you so much, and congratulations for your work.
Thank you.
Vitali, Dr. Vitali has some question for you.
Hello, Dr. Vitali.
Thank you for your discussion and your clinical activity in the last years in our division. What about regenerative therapy in orthopedics? We think is important strategy because we think that surgery is a good choice, but we think that start to speak about prevention in our activity is a good objective for our patient, and we think that is a good solution for our activity. One question: in your opinion, what change in our future therapy choice will be there from the use of therapy regenerative? And second one, is it possible to combine regenerative therapy in surgery? And if yes, why?
Okay, so in response to your first question, what changes in therapeutic choices can stem from regenerative therapies? So the use of regenerative medicine has the potential to drastically affect the treatment approach. Currently, osteoarthritis is incurable. Regenerative medicine represents a viable option to reverse the pathology as bone marrow and adipose-derived stem cells, mesenchymal stem cells, possess the ability to differentiate into the chondrocytic lineage and produce and repair cartilage. Additionally, while UKA and TKA are effective procedures, there are associated risks such as septic and aseptic loosening, resulting in revision surgeries. But most importantly, knee arthroplasty, it comes with severe risk of hemorrhage and the formation of deep vein thromboses. Regenerative medicine can reduce the need for joint replacement, and regenerative medicines are associated with minimal risks themselves. They've proven to have an excellent safety profile so far. I believe the second question was, is it possible to combine the therapies with surgery, surgical procedures? And the answer is with ACS, no. We do not combine ACS with surgery. However, BMAC and related adipose-derived stem cells, they do have the possibility to be combined with surgery, especially meniscal surgery and ligamentous repair. This is really convenient and useful because these mesenchymal stem cell therapies are minimally manipulated. So they don't add much time to a paired surgery. And combining both the regenerative aspect with the surgery allows the surgeon the ability of attacking multiple soft tissue pathologies from different treatment angles.
Thank you. Another question from Professor Ayubi.
Well, congratulations, well done work. I appreciated the fact that you recognize also that the study was not randomized, so certainly for future studies, this would, increasing the sample size and randomization would make this more robust. I have just an observation regarding the use of stem cells, because the International Society tend to avoid the use of stem cells for mesenchymal stem cells, because the definition is more mesenchymal stromal cells. That's because of the false hope that they created, not in the field of regenerative medicine of the bone, because these are definitely this is well recognized, but of the potential use also in other tissues, brain regeneration and something else. So I'm sure that you have followed the debate about stem or stroma cells, but maybe in literature you will find also this caution on the word. But the data are good. Just an observation.
I see.
Okay, other questions? Okay, thank you and congratulations.
Thank you very much.
See you soon in a few minutes to do the proclamation, okay?
Absolutely. Thank you.
Can you open the camera, please? Okay, that's perfect. Can you hear me?
Yes.
Okay, that's perfect. I start with Daisuke Yashui because it's different type of degree, and I declare that the graduate Daisuke Yashui has fulfilled all the requirements for master degree with a comprehensive final grade of 94 out of 110, and by virtue of the authority vested in me by Italian law, I confer him master degree in medicine and surgery. Congratulations.
Thank you so much.
Yashui. And for the other three candidates, I declare that these graduates have fulfilled all the requirements for the master's degree with the following comprehensive final grades. Beatrice Barbarini, 99 out of 110. Rohit Queen Kumar, 92 out of 110. And Ashuma Kaura, 95 out of 110. By virtue of the authority vested in me by Italian law, I confer the master's degree in medicine and surgery and license to practice upon the following candidates: Beatrice Barbarini, Rohit Queen Kumar, and Ashra Kaur. Congratulations for all of you. Good job, because today starts a new life.
Thank you.
Thank you.
I think that can be harder than before, but good job. Bye-bye.
Bye.
Bye.
Thank
Thank
you.
you, Professor Cellini.
Okay.